This conference will now be recorded.
Good afternoon, everyone. This is Tracy Morton at the National Resource Center, and I'm the program manager with the TASC program, and I welcome you to the TASC 90 webinar scheduled for today. I am joined in the office by a few staff members of TASC, including Nicole Clement, as well as Cami Norland and Margot Kolseth will be joining us shortly as well. So thank you so much for being part of the call today. Our call is being recorded for playback, and we'll send out that recording as soon as it's available through email, and it will also be placed onto our website. So if you're interested in listening to the recording again, you're certainly welcome to, or if you feel like you know someone or a hospital that might benefit from the information discussed today, feel free to go ahead and send that recording link to them as well. Also, after the call, we'll also be sending out a electronic survey of the call today. We're interested in your feedback about the quality of the call as well as the quality of the content that was provided and if it's beneficial to you and your role in the State Flex program. So please take a couple minutes and respond to the very short survey as we're always trying to improve these calls and really are doing all this work for you and your benefit and improve knowledge and understanding about the content in the Flex program. So please take a couple minutes and complete that assessment. We really appreciate it. I'm just going to take a brief minute here to go over the agenda, and then I have a short update from the perspective of TASC to share from you. So today our call content is really focusing on the Medicare Beneficiary Quality Improvement Project. Phase 2 data is now available, and it has been distributed through the Federal Office of Rural Health Policy to all of you, and you should have in turn then been distributing the data out to your participating hospitals. We at TASC are really proud to be a part of the MDQIP project, and we would really like to applaud all the fantastic work that the critical access hospitals are doing with reporting data into MDQIP, but also the tremendous effort that's happened in each and every State Flex program to share and sell the worthwhileness of participating in the program and engage the hospitals in learning and developing and quality reporting, as we know that's critically important to continue to be into the future. So that's our focus for the call. But first, after a short update from TASC, the Federal Office of Rural Health Policy staff, including Dave Dietz, who is the new program coordinator for the program, as well as Aaron Fishbach, will be talking to us about some updates from the Federal Office of Rural Health Policy as well as hospital regulatory changes. Following that update will be a short update from John Gale, who is with the University of Southern Maine as part of the Flex monitoring team, and he'll be doing a brief update about happenings with the Flex monitoring team and current and upcoming research. Then we'll move into the topical portion of our call today, again about MDQIP Phase 2 data review with a questions and answers portion, and that discussion will be led by Megan Meacham with the Federal Office of Rural Health Policy. We'll certainly have time for questions and comments at the end of the call, and then we'll adjourn promptly at 3:30 today. So that's the schedule of events for the next hour and a half or so. Just a short update about TASC and what we've been up to. It was really wonderful to see many of you at the National Flex Conference just a few weeks ago in Bethesda. It's always a pleasure to work with everyone, and we hope that you enjoyed the conference. Thank you to all that completed the evaluation about not only the Flex Conference, but also the pre-conference workshop of program evaluation. From the results we received, it appears that many really appreciated all the content that was shared. We had some great feedback, and we hope that in the future, again, we can continue to do a conference activity, but if not, we'll find a creative solution to be able to bring everybody together still, maybe just virtually, but to continue learning about hot topics, trends in the Flex program, and certainly sharing the state success stories and best practices with each other, too. A reminder that if you have not yet completed your activity workshops in the Flex Conference, they're now overdue. We just have a few remaining out there, but we really would like to get one. One worksheet is required per state that participated in the workshop, or I'm sorry, in the conference. If you have any questions, either contact your project officer or contact TASC, and if you're not sure if one was submitted by your state, definitely send TASC either an email or a phone call, and we can look it up for you and let you know for sure. I also wanted to note that the presentations and notes are available and posted onto a website from the Flex Conference. I just posted a link up onto the chat portion where you can find those presentations and notes that summarize the small group discussion. So take a minute and look at those as well, too. And then a couple more announcements quick, and then we'll move into the ORHP update. As mentioned at the Flex Conference, we will be releasing a document at the end of the summer here about the exciting work that was done this spring about building a critical access hospital performance excellence blueprint modeling after the ball. So look for an email coming this summer, early fall about the release of that document. It's certainly something you should share with your hospitals as well. Lastly, we're planning for our next year's program content here at TASC, and so any topic suggestions you have for webinars or virtual knowledge group calls, please send us an email or give us a phone call. We'd love to hear your feedback and what you'd like to see coming in programming. And there is also a health system development virtual knowledge group call on Wednesday, August 28th from 2 to 3 p.m. Central Time. Any Flex program coordinator, director, or Flex program staff is invited to participate in that call. Those are discussions-based conference calls, and the topic for this call will be about population health management, how to integrate that in with hospitals and maybe integration of public health with the healthcare system in your state too. If you're looking for more information about that virtual knowledge group call, which is again Wednesday, August 28th from 2 to 3 Central Time, please contact Cami Norland here at the center. I'm going to give a brief pause here for Nicole to do a technical update so we can have the beeps go away, and then we'll move on. Great, thank you. So at this time, I am hoping that Dave Dietz and Aaron Fischbach have been able to join us, and I'd like to turn the call over to them to provide an update from the Federal Office of Rural Health Policy as well as an update on critical access hospital regulatory changes. So Dave and Aaron, if you're on it is *2 to unmute your line.
Hi, Nicole. This is David. I can lead this off.
Great, thank you.
And this is Aaron.
All right, great, Aaron. I'll be pretty brief here. Just a few announcements on behalf of the office. In regards to the Flex special projects that all of you should hopefully be wrapping up at this point, project officers will check back with those who are delinquent right after Labor Day. So please, if you have not already turned yours in, turn yours in so project officers can look at them and begin to discuss what the projects are with you. To SHIP and Flex funding, both hopefully will be imminently funded. We are looking for them to be funded prior to September 1st. More information will be forthcoming as soon as we hear anything, but we are extremely hopeful that they will both be funded by September 1st. We are finishing up the regional meetings right now. Megan Meacham and I will be in Region C next week down in Omaha, so we're very excited about that. And I believe we are the last one. The NOSOR meeting is scheduled October 28th to 30th in Nashville, North Carolina. For those of you who are planning to attend, you may want to make your plans as early as possible. Being the new Flex coordinator, I'd like to spend a little time with each and every one of you, though not mandatory, hopefully definitely highly encouraged. I will send out to all of you by this Friday close of business possible slots which we can talk throughout September and October, as well as a very brief informational sheet for you to fill out. It won't take you more than 10 minutes, I promise. These talks will be about 1 hour in length and will enable you to provide a lot of feedback and your opinions in terms of what should, if anything, be altered in the next year's non-competitive. So again, this is your opportunity to speak forth, speak out, and give your thoughts. So I look forward to meeting those of you who have not had the chance or opportunity. In about 3 weeks, I'll also come out with information in regards to the strategic planning process that will involve creating the next competitive Flex grant. So all of you who are interested will be certainly invited to participate to some extent. I'm working with TASC right now and some folks internal here in terms of how we can best design this process so everybody can provide some of their own opinions, provide ample feedback, and obviously we can keep providing and producing the best outcomes possible, reflecting not only our work but HHS's work as well. Lastly, just a reminder to all of you, ORHP ACA office hours will continue through September, Wednesdays 3 to 4 Eastern Time. Unfortunately, this meeting overlaps today's office hours, But next Wednesday, again, if you have any questions in regards to the ATA, please feel free to dial in, call in, or contact the project officers. Aaron?
Okay. And my first couple of things are going to build on what Dave just mentioned.
Aaron, just hold on one second, Aaron.
Okay.
Sorry, this is Mike. One further issue is that I want to let everyone know that as it relates to PIMS this year, you will not be required to report starting at 9/1. There is a delay in the PIMS reporting due to the development of the new system. That delay will be pushed off to about mid-November. That's when the start date will be for the reporting mechanisms. This is more due to software development, so if there are any messages that come to you from EHB, please disregard them. We will try to get them disabled as soon as possible. Along those lines, we will have user acceptance training with 5 to 6 of you in late October prior to the release of new information, and we'll try to go over some of the PIMS data, or PIMS requirements prior to that. Also, the new PIMS system will be nothing that you haven't already captured. Let me stress this. Everything you've already done in your work plans, all the measures you've already done, those are what we'll capture in PIMS. There won't be a lot of data entry. It will be mostly looking at the numbers themselves. So the previous system had a lot of hospital data entry. That's not there anymore. There was a lot of dollar entry. That's not there anymore. It's going to be related to the measures themselves supported by flex dollars specifically. So if you have any questions, I will feel free to answer any of them as they relate to them, and we'll have additional information coming forward on the PIM system itself. With that note, Aaron, you're on.
Okay. Woohoo. Lucky you all. No PIMS for another couple months. I did want to mention, Dave was talking about office hours, and today's office hours are on ICD-10, and there will be another opportunity on the 23rd. Our health IT people who joined us a month or two ago will be having a call at technical assistance call and webinar at 2 o'clock on the 23rd, Friday the 23rd. If you haven't seen that announcement, we can send that out to you, but it should have been distributed to all the listservs. So look for that, and it's on ICD-10 implementation for rural safety net providers. Now turning to my presentation, my slides, if you will. The second slide is on the inpatient PPS and long-term care hospital final rule. Just wanted to note that on August 2nd, CMS issued the final rule, and it'll be published on the 19th. So on Monday, it'll be in the Federal Register, and there is the link to the display version. The key issues are that it is clarified that CAUS should be able to provide inpatient care. There are a few that aren't, and so they wanted to clarify that as a policy. It establishes the 2 midnight policy for inpatient admissions, which basically says that if a patient is going to be staying in the hospital for at least 2 midnights, then it would be appropriate to admit them as an inpatient instead of leaving them on observation care. Another one for a number of critical access hospitals. The parent tertiary hospital, a teaching hospital, may no longer claim FTE residents at critical access hospitals. When they send them out to critical access hospitals for rotations, they can't count that time. They won't get credit and get GME payments for that. CMS notes that the cause themselves could get that proportionate to their Medicare share, but only to that amount. And so we'll be interested in monitoring whether critical access hospitals continue to be interested in receiving them if they don't feel they can maintain those costs themselves. The Medicare dish payment adjustment goes into effect, and that means a 75% reduction in the dish payments for the most part, and then some reallotment based on the uninsured rate. As frequently happens, the Medicare Dependent Hospital Program is slated for expiration. One key thing there is if a hospital is a MDH now and is looking at becoming a sole community hospital, CMS made the process to transfer to SCH status a little easier, but in the process of converting, they have to give up like their rural status and such, and they won't be able to automatically get those statuses back if the MDH status were reauthorized and extended. So they've got to be careful about whether they decide to convert. And then there were a few other issues, a few other highlights there that I'm not going to cover. The next slide, outpatient PPS. This one was published on July 8th, or was issued on July 8th and published in the July 19th Federal Register with the link at the bottom. This one, they finally have decided to, or proposing to enforce direct supervision on hospital outpatient therapy services. So they established this policy, and then they put a moratorium on enforcement for the last 2 or 3 years, and they are now proposing to implement it effective January 1. So unless a provision specifically had a reclassification for general supervision, it would require direct supervision. There was also an amendment to the conditions of participation relating to therapy outpatient services and who delivers them, and making sure that they're eligible under state law, scope of practice types of things. Another one is that the Medicare EHR incentive payment program is being modified a bit to accommodate the Method 2 cause. So physicians who've been working at Method 2 critical access hospitals haven't been able to receive EHR incentive payments under Medicare for their services and for their billings under Method 2 CA. And CMS is fixing that. It's going to be effective for 2013, but my understanding is the reporting won't actually take place until 2014. And as a result, the most that an EP could be eligible for is $39,000 instead of $44,000. So the rule estimates how many physicians this impacts, and we'll be interested to see how many it actually does. And then there are a few other updates that I'm also not going to go into with you, but you have them there. On the next slide, physician fee schedule, same dates, the link to the July 19th Federal Register at the bottom. In the physician fee schedule, they applied the outpatient therapy cap to critical access hospitals. So in general, the therapy cap hasn't applied to outpatient departments of hospitals, but they revisited this policy in light of ATRA, I can't remember the acronym, Tax Reform Act, American Taxpayer Relief Act, in December. They went back and revisited it, and they decided that they should be applying it. However, because critical access hospitals are cost-based, if they use the cost-based reimbursement, the Medicare beneficiaries would reach the therapy cap much sooner. So they're going to use the physician fee schedule rates for therapy to calculate when they reach the cap. Now, thankfully, there's still a fairly simple waiver process or exclusion process. So once they reach the therapy cap, the providers can indicate that additional therapy is necessary, and they are able to continue providing those services. But if that ever changes, that could be a real issue. One that we've been working on is that CMS has proposed to redefine a rural HPSA for purposes of telehealth originating site eligibility. They're proposing to use ORHP's definition. So there are two major provisions under telehealth policy for eligibility for an originating or patient site. This is the spoke site. And that is either in a non-metropolitan county, and that will remain the same, or in a rural HPSA. Up to date, the rural HPSA has also been non-metropolitan, so it was a moot category. They're proposing to use the ORHP definition, which would expand this. We're working with CMS and HRSA to develop a website that people will be able to go to and check their eligibility status, and we hope to have that up before the end of the year, and maybe even a link in the final rule if CMS finalizes this. The other issues, the other one I would particularly note maybe for some of the hospitals with ambulance services is that they are updating the rural ground ambulance payment by 3%. That's the second bullet from the bottom. I'll let you look at the other ones to keep this moving. The next slide, marketplace navigators. The Navigator final rule was issued, and there's a link to it. The basic point is that it sets standards for the navigators, for non-navigator assistance personnel, and certified application counselors. Some additional reading there for you. The next slide is on the certified application counselors. So the guidance for them specifically was released, and the process for becoming a certified application counselor. This is an opportunity for a lot of rural providers, including some hospital personnel, to be trained and to be able to provide application counseling to the uninsured to get them signed up in the marketplace for insurance and to look at their eligibility for some of the subsidies. On the next page, the final rule for Medicaid and CHIP agencies and the marketplace has come out, and it talks about open enrollment provisions and the process for verifying employer coverage. And there's a note you might have heard a little bit about that they're not going to be able to have the verification system electronic this year, so it will be an attestation or a good faith system for the first year, and they will just simply randomly sample a few folks and contact employers for verification. And then we again provided on the next slide a link to outreach and enrollment and education resources from CMS, so that if you have any questions, in addition to our calls. And that's it. Does anybody have any questions?
Does anyone have any quick questions for either Aaron or Dave? It's *2 to unmute your line. Okay, well, thank you both very much for sharing with us today. I think, Aaron, it's really exciting to hear about those certified application counselors, and yet an excellent opportunity for the rural hospitals to become involved in the health insurance marketplace and become informed about decisions that some of their clients and customers and loved ones are making. So I encourage state flex programs to share this information. I really applaud the Federal Office of Rural Health Policy for their role in disseminating all this great information about ACA and the upcoming changes that are going on. And thanks, David, too, for your mention about the flex worksheets. Is what I'm hearing for the flex activity worksheets is that the ORHP project officers are going to start following up with states after the Labor Day holiday. So a good incentive for everybody to turn theirs in and for us at TASC here to summarize information and get it to you before then. So thank you both very much. I'd like to turn things over now to John Kale with the Flex Monitoring Team to do a quick 10-minute update about the activities with the Flex Monitoring Team. So John, it is *2 to unmute your line. And please go ahead.
Thanks, Tracy. Hello, everyone. Good afternoon. I think probably one of the more exciting announcements for us this week, not that we didn't expect it, but it's nice to have the paper in hand, is that we've received our Notice of Grant Award for the Flex Monitoring Team, and we'll be continuing our work with the state flex programs, the Office of Rural Health Policy, and all of you at TASC. So we're excited about that. This is really an area of work that's a lot of fun for us. So I'll just go over very, very briefly some of the projects that we're involved with. One of the big areas of work that we are doing is that each of the three centers, North Carolina, Minnesota, and ourselves, each have areas that we're working on in terms of creating state and national reports regarding the activities of critical access hospitals. UNC being finance, Minnesota being quality, and USM in Maine here doing community work. And what we're working to do and exploring the development of a consolidated hospital level report using data for each of these three areas. And we're in the process of developing the feasibility report to do that. It's not an easy task, but our goal would ultimately be to have one consolidated report similar but more extensive than the hospital level reports that you receive from UNC at the moment. And we'll be working on that in the year to come, and It's not without methodological challenges, but we're excited about it. Some of the other areas, UNC is going to continue their work with finance and looking at those studies in Minnesota's quality. Certainly, they've got case studies in the works on the implementation of ED transfer communication measures. In Minnesota CAH's, they're analyzing the MB-QIP and the hospital care quality data, and the qualities, and certainly are working on their section of the single report. And Michelle will probably hang me if I don't mention that we are in the process of revising and making our website for the monitoring team, which provides access to all of our products and work and the list of CAHs across the country. And that's being revised now and will be available in the fall. We're working on a couple of projects now, and including work in looking at the evidence base for community paramedicine. We've interviewed a number of state flex programs and state EMS agencies regarding their activities. We're in the middle of our case studies of critical access hospital turnaround activity. What we're trying to understand is how a critical access hospital that has been struggling financially is able, and the different strategies and the combined strategies that they are taking on to improve their financial performance. We use cost report data, financial data, and the UNC distress index to select three sets of candidates. It's a little preliminary to identify them, but we're moving through that process now and have been going through and looking at financial issues and past work with struggling hospitals, and that'll be out sometime this fall. Going forward, we have a variety of community topics. We're looking at, for the coming year, exploring the collaboration between critical access hospitals and public health departments, being very important around population health, service development, and the community needs assessments. We're getting ready to release reports on the community benefit activities of CAHs through the analysis of IRS 990 data. We will also be working on a project this fall to identify, our new project to identify quality measures and looking at quality improvement strategies and issues for local EMS departments. So I think I'll wrap that up. That's sort of what we're doing in a nutshell. Certainly, as always, feel free to ask questions now, or if you have any questions about any of the work that we do, the contact information is on the FMT website.
Wonderful. Thank you, John. Does anyone have any questions for John? It's *2 to unmute your line. Okay, well, thank you very much. I know I'm really excited about that consolidated report combining all core areas of the FLEX program, so I'm really looking forward to seeing that. Thanks so much for sharing today, John.
My pleasure. Thank you.
And now we'll move into the main topic of today's call, and so I'll invite Megan Meacham then and whomever else that might be talking from the Federal Office of Rural Health Policy as well to walk us through the Phase 2 data review for MB-QIP and some of the questions and answers you received in your office ahead of time, and any other questions or comments we might have today on the call. Megan?
Sorry, it was already unmuted. Thanks, Tracy. And just before we get started and dig into the reports, I just want to echo what Tracy said at the beginning of the call and thank everyone for their hard work. You know, we definitely know that this has not been the easiest process for you all. There's been a lot of selling to your hospitals, and then there's been work on the hospital's end as well. So we do appreciate that. And I think Michelle Casey shared it at the Flex conference, but all of your hard work has actually resulted in an increase in the outpatient reporting. It had been really low nationwide amongst CAUSE for the last few years that they've been tracking it, and I think 2011 it was about 27% of hospitals, and you know, we like to think that as a result of MB-QIP being the largest driver. Last year for 2012, we actually saw 57% of critical access hospitals submit outpatient data. So this is definitely, you're making an impact, and then as we continue to get more data, we'll be able to use that data to drive the quality improvement piece. So with that, I just want to walk you through some of the reports. So what we'll do first is go through kind of a snapshot of the reports along with a legend, and then there's also a Q&A document. I think Nicole sent these all to you, so you should have them. So we'll go through all of that, and then we'll open it up at the end in case there are any questions that aren't addressed through these two documents that we'll share with you. So I apologize that these are a little bit small, but hopefully you've looked at your own report, so you're at least familiar with each of the columns. So we'll just kind of walk through here. I've highlighted a few points that are important to note. So the first one is number 1. It's in that first column, kind of in the middle left. And you'll see that on this outpatient hospital report, sometimes you see an NA of NA, and sometimes you see a 0% of 0 patients. And that's, kind of the issue we had with the inpatient was that they couldn't always distinguish between whether someone just didn't report or if they just reported but they had no eligible patients. And so the nice thing about these outpatient reports is that it does distinguish that. If a hospital, so you can see on this sample hospital, for the first 2 quarters, this hospital just wasn't submitting any data. And then in that third quarter, where number 2 is, you see that they actually did submit data, but they just didn't have any patients for some of the measures. So it'll help you distinguish just that by glancing at the report. The next one is number 3, which is the state performance and the national performance. And these columns are the totals only for those CAUs participating in MBQIP that actually submitted data. And that's going to be the state performance for the most recent quarter and the national performance for the most recent quarter of data. So it's just 1 quarter, and then it's the state and national performance for MBQIP data submitting hospitals. And then 4 and 5, what's in columns 4 and 5 for the state and national performance, that's going to be the same data that you see on the state report under the same title, the state performance and national performance. So number 6 is, that's going to be your most recent quarter of data, and this should be pretty familiar to you because the outpatient reports are pretty similar to the inpatient reports. But that number 6 is showing you the most recent quarter of data. So that's the 4th quarter of 2012, which was the most recent quarter of data that the hospitals reported. And then when we have another quarter of data, they'll all shift to the left. That 1Q12 at the left will roll off, and then we'll have a new quarter of data in that far right column, which will be 1st quarter of 2013. There's also on the left, the number 7 and 3 arrows pointing to the median time measures. And what's important to note is ORHP had a call with Telegen just to make sure that we understood the reports as best we could. And these median times are, first of all, median is the middle. So it's going to be however many patients your hospital say transferred, whatever those times were, whatever that middle time was. So if there were 3 patients, patient 1 would be the low, patient 3 is the high, and then that second patient in the middle is the median. And all of these median times were equally weighted. Telegen didn't drop out any numbers. There were some that may have been an error. They seemed really high, but we'll talk about that a little bit in the next, nope, right now actually. So, so if you bring your attention back over to the far right of the report, there's two circles for two of the median times. One is 117 minutes for time to transfer, and then one is like 170 minutes on time to EKG. And some people did mention that those times seemed a little bit high for a national average. And so what's important to note with that is that because Telegen didn't drop out any data for data integrity purposes, there were some hospitals that reported over 1,500 minutes to EKG, and that's, you know, it's unlikely, but at the same time, Telegen doesn't have a threshold, and so they can't look at the data and say, well, this number is not accurate, so we're going to drop it out. So for the purposes of these reports, all data is included. So just keep that in mind when you're looking at it. It may kind of skew a little bit those numbers, and really what we want to use is gauge your hospital performance based on their characteristics and what should be expected of them and their time. So that's a good way to look at this data. And then the next slide, and this references for you, is a legend explaining all the points on that report. So you can share these resources with your partners, your hospitals, whoever might find them useful. So the next slide is the outpatient state report. And again, this is going to be the rolled up data for all hospitals that are participating in MBQIP that submitted data in your state. So each of those 4 quarters is going to be all cause in your state that reported data. And then that your state performance aggregate, number 2 column, is the aggregate of the 4 quarters that are on the report. So this particular aggregate is the aggregate of first quarter 2012 through fourth quarter 2012. Column 3 is, again, the same as what was on the hospital report. It's your state average for the current quarter of data. So you'll notice that the far right, fourth quarter 12, and the third column, state performance, are actually identical. It's identical data. And that's, again, all cause in your state that submitted data for that quarter is calculated in the state performance. And same for the national performance. It's all cause in the nation that submitted data, and we have an MBQIP MOU on file. And for fourth quarter of 2012, there were 1,230 critical access hospitals participating in MBQIP, and 643 of those actually submitted data. So that kind of gives you the universe of how many cause are accounted for in that national performance number. And then again, just with this median time, something that we're going to work with Telegen on to try to get addressed for future reports. Some states, I don't think that there were many, but some states did have quarters where no hospitals submitted any data for some of the median time measures. And so the state aggregate is calculated divided by 4 quarters. It was so if you have a 0 in one of those quarters, that 0 is going to be calculated in with that aggregate. So it's going to skew what your aggregate number is. So on the next slide here, I just that bullet under number 5 is an example. There was a state that had 7 minutes in one quarter, 20 minutes in another quarter, and then they had 2 quarters where there were no patients. And so the aggregate should have been 14. You could do 7 plus 20 divided by the 2 quarters that you had patients. But instead it was divided by 4, so the aggregate came out to 7. So we'll work with Telegen on that calculation just to make sure that we're trying to get you the most appropriate and accurate data we can. Next we'll move on to the HCAHPS report. And the HCAHPS these ones look a little different than the inpatient and the outpatient that you've seen, but essentially the same data is there. You're getting the data for each reporting period. You're getting hospital data, and then you're getting state and U.S. data. Each report is 2 pages, just because there's a few more measures that are reported. The most important thing to note with the HCAHPS reports is that you're being provided HCAHPS data. You're not getting HCAHPS scores. This data has not gone through the cleaning and the scrubbing and whatever else the HCAHPS contractor group goes through to create those HCAHPS scores for hospitals. So this is just for the hospitals to see what their data looks like. And then of note on these, the hospital report is each column accounts for 1 reporting period, but with HCAHPS, a reporting period is 4 rolling quarters. So each of those columns has 4 rolling quarters of data within it. So if you look at the left to the right, you're actually getting second quarter of 2011 all the way through 4th quarter of 2012, but there's going to be overlap of 3 quarters within each of those reporting periods because it's a rolling 4 quarters. And then the other important thing to note about these is that the way that Telegen was able to access the data, the state and the national data is not just for critical access hospitals, and it's not just for those participating in MBQIP. The state data and the national data is all hospitals, rural, PPS, urban, any hospital that submits HCAHPS, that data is included in the state and national averages. So we understand that it's not giving, that perfect hospital to state comparison like some of the inpatient and outpatient data, but it's still providing data to open up conversations with your hospitals, and we're succeeding in getting our hospitals used to reporting this data. And then just to show you, again, here's the legend for some of those, and just to show you what the state report for HCAHPS looks like. Again, this is, it's all data, and it's all hospitals within your state. So each of those 4 reporting periods is for every hospital in your state, not just for critical access hospitals. And then that state aggregate column, the number 2, is the state aggregate across 4 quarters, or 4 reporting periods, I'm sorry. But they weren't really able to calculate an aggregate because of the 4 rolling quarters and the some of the quarters overlapped from reporting period to reporting period. So we'll work on getting this column removed for future reports because it's not a useful column at this time. And then again, just like with the inpatient and the outpatient, that state average and U.S. average are for the most recent reporting period. So it's that whatever the most current quarter and reporting period is, that's the data that's in those columns. And again, the legend, and then I think we'll switch to the Q&A document. Please, Nicole. We'll just go through a couple of these, and then I'm sure there will still be some questions, so we're happy to take some of those as well. And also, I just want to mention that we understand that the turnaround was quick for this. Some of you didn't have a chance to get this back out to your hospitals because for those of you that we were able to email them to, you maybe had a little extra time. Because of some state email firewalls, we have to actually ship out a disk. So, we fully understand that you may not have had a chance to gather all the questions yet, but we're hoping that with these resources and this call and your opportunity to ask questions, once your hospitals do get them, you'll at least, you might be equipped with some of the answers already. And then if you do get any questions that haven't been addressed, feel free to reach out to your project officer, and we'll make sure to work on an answer for you. So again, similar to the inpatient reports, we put together a Q&A document. Some are based on questions we had ourselves for Taligent, and some are from what we got from those of you that did give us questions. So I think we'll just briefly walk through each question, and then we'll open it up. So similar to the reports you've been getting in the past, if you think that you're missing any, that if you know a hospital is signed up for MBQIP and you think that their report is missing, just reach out to us and we will look into that for you. A little bit more on understanding the report. Some of these questions have we've already covered walking through the report. For instance, the NA. It does mean that no data was reported for the hospital, and that 0% of 0 patients indicates that the hospital reported, but they didn't have eligible cases for that measure. Also, there may still be an issue with a hospital getting confirmation that their data was uploaded through CART, but the report still shows NA. One possible reason for this is that the CMS data warehouse accepts their data, but it may not have been an eligible case, in which case it doesn't end up in the data that Taligent actually pulls. Taligent is only able to pull eligible cases. So, make sure that the hospitals understand the CMS and inclusion criteria. And I believe that's all available on the QNet Warehouse website if they have any questions about why their cases are being not included in these reports. Also, there is a subtitle on the outpatient report that has, it says reporting period for outpatient imaging efficiency measures. We will work with Taligent on this. We don't believe any of the measures are efficiency measures, and so we will get that removed. We talked about the outpatient or the state and national performance data. It's for all hospitals that have signed up for MBQIP and have submitted data or submitted eligible cases. Also, just another explanation of the median times for the state performance and the national performance and why it may seem high in some states. So I think the important thing to note here is that this data is not necessarily intended to show that a hospital did really well or did really poorly, because based on geography, a hospital may just be really far from the next. Like if it's the transfer time, it may be 2 hours, may be the best they're able to do. And so we don't want to fault anyone or say, oh, well, you're performing worse than the state or national average. That's not our intent. Really, the important thing is to get to know what's the capability of that hospital, so you can understand and you can have those conversations with them. So when you do see an outlier number that seems inappropriately high, you can talk to them, hey, what was going on? Or it might be, you might also be able to identify which hospitals need assistance in reporting data, because if they entered in, 1,700 minutes, maybe they only meant to hit 17, and so it's a teaching opportunity as well. And I think, just to call out one of our states, Beth McCullough has always been a proponent for, some of the hospitals, they have one hospital where patients would either have to get on a ferry or they have to send out a helicopter. So there's no way that hospital is ever going to have really quick transfer times. So again, it's just understanding the situation for your hospitals in your state. Again, with the median times being divided across all 4 quarters, even if there weren't any patients, we'll go ahead and work with Taligent on that. So hopefully for future reports, we'll have a better median time for the state and national numbers. And one other question that we got on the outpatient reports is in reference to outpatient 4 and outpatient 5. Those measures are both AMI and chest pain measures. And so we're going to check with Telegen and CMS to see how CMS is reporting those numbers, whether they're aggregating the two together or if they're reporting them out separately. We're not entirely sure. We'll have to check, and then we'll get back to you. So, and if CMS reports them individually, like let's say they report outpatient for AMI and then outpatient for chest pain, we'll want to do the same. So we will look into that and get back to you all. Moving on to the HCAHPS reports, again, you're not getting HCAHPS scores, you're getting HCAHPS data. And the state, question 10 there is the HCAHPS state and national data are all U.S. hospitals reporting to HCAHPS, not just critical access hospitals. The next question, NA on the HCAHPS reports does mean that there was no data for Telegen to pull. The most likely cause for this is that the hospital didn't participate in HCAHPS and didn't submit data. However, we do know that unlike the inpatient and the outpatient data where we have access to even the small numbers where there's only one patient, HCAHPS, I don't know if it's 5 or 10, I forget what the threshold is, I'd have to confirm, but they're not, it doesn't even go into the warehouse. And so it's not even there if it's that small volume below 5 or 10 respondents on the HCAHPS survey. That data is just not there. So if you have a really small volume hospital, even if they're participating in HCAHPS, that may be one reason that the report shows NA, even though they do participate in HCAHPS. Again, we talked about the state aggregate column. It was a calculating issue. And then, as you all know, the whole point of MBQIP is the first point is to get hospitals used to reporting, but then we also do want the data to be used. And so just a couple questions or a couple of points on how you can continue to use the data and work with your hospitals. We also sent out, Nicole sent out, there was an MBQIP guide for reviewing the data, and then there was a flow chart that can just kind of help give you some questions, some conversation points when you talk with your hospitals, figure out, where in the process improvement is needed, whether it's at the data abstraction and reporting level or whether they're ready to start moving into implementing quality improvement activities. So we just encourage you to have those conversations with your hospitals. And we want to hear from you too, how you're using these reports, feedback on the usefulness of them, and any innovative or new things that you're doing in your state. We love hearing about it. We definitely want to make sure it's shared amongst other states as well so we can all keep learning from each other. I think with that, there's a couple of us from ORHP here in the room. We'll try to answer your questions, and anything we can't answer, we will write down and check with whoever we need to check with to try to get an answer.
Thank you, Megan. This is Tracy. I think maybe let's first start with the question in the chat box. Captain Miller had typed, can you clarify what you mean by data, that these numbers, referring to the HCAHPS numbers, are data, not scores?
Sure. I can try, and then I can check with Telegen to make sure I'm explaining it properly. But I think what that means is that when you look at the HCAHPS report, it's telling you, how many respondents responded with, I forget the exact categories, but it's the, almost always or always. I think there's 5 categories of responses on kind of the Likert scale. So it gives you so it gives you like the number of respondents, or the the percent of respondents that answered always, the percent of respondents that answered usually, and then the percent that answered, sometimes to never. And it tells you kind of what that universe of how many completed surveys there were, how many were actually, what the survey response rate was. But, I don't know what the algorithm is that the HCAHPS data group goes through then to turn this into an HCAHPS score. But what they do with it hasn't been done with the numbers that are on this report. So these numbers may actually look very different from what comes out when the hospital compare data is publicized. So again, just keep that in mind if you try to compare this data to what comes out. It's going to go through a lot more scrubbing. You're just getting kind of the uncleaned raw numbers, whereas the HCAHPS score takes into account all that cleaned and scrubbed data. So I hope that kind of helps.
Thanks, Megan. This is Catherine. So I guess what I'm trying to clarify is, and maybe you did, you said it would be number of respondents. Maybe could you flip the slides back to one of the HCAHPS reports, because I don't have it in front of me either.
Yeah.
Thanks.
Can I do that, Nicole, or do you have to?
I'll get it up for you. It might just take
Thank
me a
you.
second.
Yeah, so I think I'm understanding what you're saying is it's straight raw data of number of people, or not number of people, but the number of scores. So if 5 people said always as an answer, then it would say 5?
It would be the percent of the surveys. So if 100 people responded or if 10 people responded and 5 people said always, then it would be 50%.
Okay.
Or for this one, is that the 78% for this hospital said the nurses always communicate well.
Megan, this is Paul. If I might share my understanding of it, when we had the discussion with the HCAHPS folks, this data has not been scrubbed, and when they put the HCAHPS scores up, that's why a number of them would have an asterisk on your hospital compare website. So we've said that we're not going to scrub the data. We're going to put all small numbers that would normally not be reported. When you get a chance, and this quarter's data is actually published on the hospital compare website, that will be the best way to tell what the difference is. Compare what you got with data to what they have with scores. But what it boils down to is we're not scrubbing according to low numbers, inadequate number of responses, or some of the other criteria that they scrub to. Hopefully that's helpful.
Yeah, and I think that's a good point too. It might help you. As much as we're saying, don't compare these numbers to what comes out publicly in the, how are we doing comparison, but it might be worth comparing just to see what the differences are. Is there any other questions?
Well, an observation, Megan, this is Kevin Driesen. I assume on that first column there where it says sometimes to never, that should say percent sometimes to never, right? Your other two columns have percents, and I think that sometimes to never is also a percent?
Correct.
Okay. The other thing I would say is we do get some complaints from our, or not complaints, observations from our hospitals about their concern around this adjusted scores that differ from their own scores that they get from their vendors. So it may be down the road at another conversation we can have about the process of adjusting, because we do get from a few of our hospitals, it's not isolated, concern about that adjustment process.
Are you talking about the final HCAHPS adjustment versus what they're getting from their vendors?
Right, toward the top there. Right, toward the top it talks about your hospital's adjusted for.
And we're actually going to get that language changed. We had been told by the HCAP contractors that we couldn't use the term HCAP score. We didn't share that with Telegen, apparently. So we're going to have that. It's not actually an adjusted score. It's just data. But I think that it's a good point. We need to have further conversations so we can better understand what these differences are.
Hi, this is Mary Sheridan. I have 2 questions about the HCAP report. The first is that you mentioned that the state and national data, this is all hospitals submitting HCAPS data, correct?
Correct, yep.
Is there a reason why it's not just MBQIP, critical access hospitals?
Yeah, my understanding was that they didn't get the data in a way that it could be broken down. They just got a state dump and a national dump, and it didn't identify who the responses were coming from, or what type of hospital the responses were linked to.
Is there a plan to see if that can happen so that it is just critical access hospitals?
Yeah, I mean, we'll look into it, but I'm not, if that's the way that the data is being collected from so Telegen is the contractor that collects the inpatient data, and then there's another contractor that collects the HCAPS data, and Telegen's getting it from them. If that's the way that their warehouse is set up, I'm not sure that there will be a way, but we'll definitely look into whether there is a way, and if there is, we'll try to get that.
Okay, thank you. And my other question is, I thought that you said if a critical access hospital had a very small number of HCAP surveys in that quarter, that their report might not show that. It might show zeros. Is that correct?
Yeah, I think it was, Telegen said that they didn't see any hospitals with fewer than 10 respondents.
So if they had fewer than 10, they wouldn't receive anything on their report?
Correct.
Okay, thank you. And that is for a quarter, if there were less than 10 in a quarter.
That's a good question. I'm going to have to, because it's a rolling 4 quarters, I'll have to look into that. So does it have to be 40 per rolling quarter, or 10 per? We'll look into that one.
Okay. And I guess my concern there is for hospitals with small volumes, I guess what then is the value? How do we encourage them to continue to participate if they're doing it and paying a vendor but then just seeing zeros on their reports?
Yeah, and I think some vendors do at least share the data back with the hospital. They might not be submitting it to CMS because they don't have to if it's lower than a certain threshold, but there are some vendors that we've heard more specialized, I guess, more in the smaller rural market, and they do, so even if a hospital only has 5 responses for an entire quarter, they'll still give that data back to the hospital. So again, it might just be a conversation to have with your hospitals and see if at least their vendors are willing to do that.
And okay. And I think my one concern as far as HCAPS is that for the last couple of years we've talked to them about MBQIP and how small numbers is now not an issue, and this is for you, and you'll be able to benchmark against CAHs statewide and nationwide. And that concerns me that now what we're telling them about HCAPS is different from that.
Yeah, we completely understand that. And hopefully we'll find out that somewhere hidden in the database, those small numbers are there somewhere. Or, again, at least having, if they can use the data just to compare, if they can get the data from their vendors even, and then just kind of use the data to gauge their own internal improvement. And they can, you kind of start to benchmark against all hospitals in the state and all hospitals in the country as well. But we completely understand and that these HCAHPS reports aren't a perfect product, and some will find them more useful than others, and some will, they'll just be of more use to some than others.
Hey, this is Kenny in South Dakota, and I have a question regarding, you said that, some hospitals, their data might not be accepted if by CMS. Would they turn up as being a NA of NA or a 0 of 0 if it turned out that none of their cases were accepted?
I'd have to confirm that, but I'm pretty sure it would be a 0 of 0, because if they submitted, because they still submitted data, they just didn't have any patients that met the criteria for that measure. So it should be 0 of 0, but I'll confirm.
That's kind of what I thought, but you never know. If it doesn't, if nothing goes through, it might end up being NA of NA.
Yeah, no, that's a great question.
This is Ellen, and I'm from the QIO, and I just wanted to ask, so how are the cause to identify that they have 0 eligible cases? Where are you getting that data?
You mean like how is the CA reporting that they had 0 eligible?
Right, or how is Telegen able to know that? Are they expecting that they're going to put it in their population and sampling size? Because if they have cases that they're reporting on that aren't OP 1 through 7, that warehouse may accept cases, but they won't be the measures that are in MB-QIP.
My understanding of Telegen, all of the data gets dumped into the data warehouse, whether it's an eligible case or not. But when Telegen, like the way that they run the data is that they only pull the eligible numbers. So if a hospital,
but if they have no patients to report,
yeah,
how are they able to tell Telegen that they have no patients that are eligible, so that they get credit for the fact that they had nothing that they could report?
So I'm assuming that the issue is similar with the inpatient, that in the CART tool they can't enter a 0. Is that correct?
That is correct.
Okay. So in that case, then there may be some NAs on the report that if they just skipped the measure because they knew they didn't have any eligible patients, it may show up as an NA. And similar to the inpatient reports, that's not something, because so many hospitals are using the CART tool, that's not something we can really, there's no workaround at this time for that. So again, it's just up to the flex coordinator to have those conversations with the hospitals and to understand. So if they know that their hospital is using the CART tool and they've got data in some of the other measures, but they've got one measure that says NA, they can say, oh, well, I know that this hospital is using CART, so therefore that NA most likely means they just didn't have any patients. Some are using population and sampling, so that would be one way that they are getting the 0 in there.
And is Telegen looking for that population and sampling field, or can they look for that so we could instruct our hospitals to make sure that if they have no cases for those 2 categories, that they make sure they put 0s, which is what I'm telling them we should be doing, hoping that they would use that for both the inpatient and the outpatient side?
Yeah, my understanding is that intelligence getting the data in whichever method they're entering it.
Okay, thank you.
Yep.
Hi, this is Angelica. I just need some clarification with the zeros. I was under the understanding that the hospitals were not able to enter zero. Is that still the case or not the case?
It sounds like in the CART, if they're using the CART tool, that you cannot enter a zero. But if they're using the population and sampling method, then they can enter a zero. But I think similar to Kenny's question, if they enter data, then the system still, if they enter data into CART, even if none of those patients are eligible, the system still acknowledges that data was entered. So I think that that would default to a zero. So the zero could have two meanings again. It could mean that there were no eligible cases, or the NA could mean that they didn't have any eligible cases, but they were using CART and they couldn't enter a zero, so it just defaults to the NA. Did I just submit?
And is that different than how the inpatient reports are?
It doesn't sound like it is now. Yeah.
Megan?
Mm-hmm.
Could you go a little bit into the rationale behind these rolling periods? And I'm looking at a report that has sort of 4 sets of columns to it. And there are these rolling periods from the Q1 of 11 to the first quarter of 12, or the third quarter of 11 to the second quarter, et cetera. What's the rationale of having rolling periods as opposed to just reporting for that quarter?
And you're talking about like the HCAPS hospital reports? That's an HCAPS data. That wasn't our decision. That's the way that the HCAPS data is. So I guess one thing that I don't know well enough whether when it's reported publicly and they do get an HCAPS score for a reporting period, is it for one quarter or is it for a reporting period? Our understanding when we talked to the HCAPS group was that the reporting period always consists of that rolling 4 quarters. But if we find out that it's doable in a different way and that would be more useful, we could definitely look at doing that. But my understanding is that this is the only way the data is available.
Kevin, this is Paul, and I just remind folks that the PPS hospitals, these scores are used to adjust their payments. And because of that, CMS doesn't want rapid spikes and falls from quarter to quarter. So by rolling the quarters, what they have done is they have smoothed out by averaging. It's still each column will still reflect the change that is implemented by the most recent quarter, but it also does it on a rolling 4-quarter movement so that you don't get these rapid spikes and falls in the data. That's not I don't know the rationale, but to me that would be one explanation of the fact of how this data is being used for the PPS hospitals, and the fact that it does affect how they get paid. And possibly taking some of the variability out of it.
It's also a common way to look when you work with small numbers is to use rolling numbers, and so to me, I think it's a pretty good fit for critical access hospitals.
Thanks for putting a positive spin on that. Are there any other questions for right now? again, we're available after this call as well. This isn't your last opportunity to ask questions by any means.
Hello, Megan.
Hi.
This is Deb McCullough out in Washington State. And I just want to say, as you know, I'm struggling with these HCAHPS reports, but I do see one thing of value on them, and that is when you see the part about the reporting rate for hospitals, if you see that they have a lower rate than their peers, you can talk to them about working with their vendor, about putting articles in their local newspapers, about communicating within the hospital and to their patients. There are very definitely things vendors can offer them. And we found one of our hospitals that had a low reporting rate. I had a CEO who said, no, I don't want to have you tell the patients about this. So that's, quite frankly, the one positive thing I can find on that one report.
Yeah, I think that's a wonderful suggestion. And I always appreciate your willingness to, just be open and share your honest opinion as well.
Thank you.
And if anyone has any questions about what suggestions she just gave, feel free to email your project officer and we'll make sure to get that back out, because I think that is another great way to use this report, even if you don't see that the data is maybe of as much value as some of the other reports that you're getting.
Megan, I have a question.
Sure, go ahead.
Did I hear you say there's more than one way to report other than the CART tool?
Yeah, so I don't know the specifics of it, but there is also a population and sampling method. I've heard different things from different people. Some say it takes a lot more time. Some have said that it's not much more effort for the hospital. Both ways they're still going into the data's still going into the same place. And then there may even be some hospitals that are working with a vendor to add in a third way to report. If they're working with a vendor to help them with their data abstraction, that vendor might be sending the data to CMS for them.
Okay. This is Ellen from the QIO, and yeah, the population and sampling is just something that the PPS hospitals have to put into QualityNet. It's a screen on that page, and they have to put in their total population that they are sending in, and if they're sampling or